Good morning, everybody. Welcome to the Four Loves family. And here today we have a special webinar with a special guest from London, Eric Rosenthal, Professor Eric Rosenthal, a pediatric and adult hemodynamicist for the Evelina Hospital, that is making a great contribution to our presentation. Pablo, please introduce the panelists and go on with the, our activity.
Okay, good. Good morning, everyone. It's my pleasure to present a great team. We worked together in this case, and not all these guys were here, but a whole team in Brasilia and Rio de Janeiro. I want to introduce our good friend, Ariane Pacheco from Vitória, Espírito Santo. Good morning, bom dia.
Good morning. I'm so glad to be here again.
Yeah, he's our CT expert who helped us to understand better this pathology, and this was so exciting. Also, we are going to introduce our good friend Anderson Terrazas from Manaus. Hi, Anderson. Good morning.
Good morning, you all. It's good to be between friends.
And he's an expert from this device, and he's going to show us how to use this device properly. And we are going to start with Professor Eric Rosenthal from London, Evelina Children's Hospital, who is our special guest. He's a leader in this field of Sinus Venosus ASD, and I know he's gathering information in an international registry with more than 300, I suppose, patients so far from all the continents, and we are going to learn a lot from him. Please, Professor, you have 25 to 30 minutes to do your presentation. Thank you to be with us.
Yeah.
Thank you very much for that introduction and for the kind invitation to join you. It is an exciting field, and we've been doing this for several years now, and I'm quite pleased to be able to show you what we've achieved and hopefully how this technique is spreading and going to become something that will really take over from surgery. Is my presentation showing now?
Yeah, it's okay.
Thank you. So, great. So I'm going to talk about percutaneous treatment for sinus venosus ASD. I'm going to go through mainly the Evelina experience, but then also touch on the registry that we're running. So for those who are new to this field, the sinus venosus defect sits at the bottom of the SVC and the top of the atrial chambers. And the defect is such that the SVC overrides the right atrium and the left atrium, and the pulmonary veins typically come in at the back. And this creates a left to right shunt with anomalously draining pulmonary veins. And the aim of the covered stent is to divert SVC flow through the stent into the right atrium, but at the same time, it closes the defect, allowing the pulmonary veins to drain directly into the left atrium. And previously, this was thought to be entirely a surgical disease, but we know now that catheter treatment is good. Veins don't always behave the way you like them to. Here you see a very high vein, which clearly cannot be connected with a stent. A surgeon might be able to, but with a stent, unlikely. So the strategy is usually to put a stent just below the level of this vein, and while the other veins drain into the left atrium, this vein will continue to drain into the right atrium through the SVC. Sometimes you need a longer stent, and if you put a covered stent all the way up there, you will block this pulmonary vein, which we don't want to do. So ideally, you would have a bare metal stent at this level and a covered stent lower down. The other problem with pulmonary vein can be they're having a vein that doesn't drain quite as posteriorly, slightly more anteriorly, slightly higher, And the concern is that when the stent comes in, you may end up blocking this vein. And this is the time where balloon interrogation of the defect helps you decide whether this vein will be divertible or whether a stent in that position would block the vein. So what do you require for sinus venosus stent closure? You need to be able to have a stent that adheres to the non-stenotic distensible SVC, and really we need a length much more than 2 centimeters for security. Ideally, if you flare it into the azygous or innominate vein, this stops the stent migrating. The stent needs to be wide enough to seal defect at or just below the SVC-RA junction. Most current stents go up to 34 millimeters, but in some patients, the defect is even bigger and these may not be suitable. Stent shortening may leave a gap inferiorly if you don't have a long enough stent. It's important to avoid compromising the pulmonary venous return to the left atrium. So this is a typical example, and with 3D reconstruction, we no longer have to print models. Here you see the SVC joining onto the right atrium. The pulmonary vein joins into the SVC, and together they join onto the left atrium. And when we spin it around, you can see the anatomy clearer. A stent in this position will therefore allow the pulmonary vein to drain into the left atrium. By doing these 3D reconstructions, you get a good appreciation of the anatomy and what you're likely to achieve with stent implantation. And we find this type of investigation really helpful. So in this particular patient, we start off by blowing up a balloon in the SVC-RA junction. We inject in the SVC and confirm that we've occluded the SVC. We know what diameter the SVC is for stent implantation. We follow that by doing an injection in the right upper pulmonary vein. We do a transeptal access with a 8 French sheath that allows constant measuring of left atrial pressure, and a catheter in the pulmonary vein that we can give angiography and monitor pressures. And here you see completely unobstructed flow to the left atrium, and that's confirmed in the lateral. Notice also this bulge in the balloon, which is unlikely to occur with the stent. The stent, a balloon expandable, is unlikely to fill this gap. A self-expanding stent, however, may fill into this gap, and this is one of the trade-offs where self-expansion may cause a problem. However, in this particular patient, even this bulge does not compromise the pulmonary vein. We like to do hemodynamics. Here you see the right atrial pressure in yellow and blue and red for left atrial and pulmonary vein. And as the balloon is inflated, you notice the right atrial pressure falls and the left atrial pressure and pulmonary vein pressure rise simultaneously without a gradient, often to a very high level. And this fall separates the two pressures, whereas before they were completely the same. Echocardiography confirms this. Nice laminar pulmonary vein flow into the left atrium past the inflated balloon, normal pulmonary vein Doppler trace, and reversed A because of the high pressure you're seeing in the left atrium now. And so we implant a stent, and you can see immediately there's a leak at the bottom here, perhaps more easily seen in the lateral projection, where you can see this jet across there. Notice that if you flare the stent at this level, you're unlikely to be able to create a seal because the SVC-RA junction is enormous at this level. However, if you flare the stent higher up, which we've done at this point, you now achieve complete seal of the defect. And here on the lateral, you can see completely unobstructed flow from pulmonary vein into left atrium. There's no leak anymore, and we'd like to think a perfect result. There's a good deal of stent there to make sure the stent doesn't migrate, and we've sealed the defect. This was a case before we had the longer 8 centimeter stent. Using a 6 centimeter stent, we thought we were adherent. We started to flare the bottom and the stent slipped off. Fortunately, we have the long sheath that you can then use to push the stent back up, and then from the jugular access, we place a second bare metal stent to seal it, giving you good adherence now to the SVC. And when you inject in the pulmonary vein, you now have good flow into the left atrium and there's no leak. And we've also been able to flare this once the stent has been anchored. You'll also notice this catheter course is from our original approach where we went retrograde arterial into the left ventricle, left atrium, and back into the pulmonary vein. It's far too cumbersome, and the transeptal approach is much simpler. This was our patient number 20. We used a 7-centimeter stent. There's a little residual leak. We flare the stent. We stretch to the top to make sure it's adherent. Stretch a bit further, tiny leak still, further stretching. Notice how the length of the stent has shortened considerably. And perhaps we didn't recognize that we only had a very small amount of stent adherent. And not surprisingly, a few hours later, the stent was in the RVOT, and our friendly surgeons had to take it out and repair the defect. Bench testing shows that if you use the 8-centimeter covered CP stent, depending on the diameter of your SVC, the stent shortens considerably. Here, with an 18-millimeter diameter SVC, we get nearly 7 centimeters. But when the SVC is up to 30 millimeters, the stent is shortened to 5.5 centimeters. And it's important to take that into account when placing your stent and choosing the length of stent. This is a patient who's had previous surgical repair. He's got a residual defect and anomalously draining vein. It actually looks quite a small defect, but in order to be able to close it, we still have to put in a fair old stent. Let's see if it'll run. Okay, I can play it like this. You can see with balloon sizing, there is still a residual leak at the bottom, but once the stent goes in, we've now got complete flow into the left atrium, and you can see now how big that pulmonary vein is. And the amount of the shunt there was. Yeah, here's a woman with what we considered previously to be a borderline defect, and in many centers this would be abandoned. You can see contrast holding up in the pulmonary vein, and there's only a tiny jet of flow into the left atrium. That's using a conventional sizing balloon. If we use a smaller balloon, there's better flow into the left atrium, but there's still contrast hold up. If we use an even smaller balloon to test it, very good flow, fast flow, no hold up in the pulmonary vein, but now you see quite a size of a leak, suggesting we would need a balloon or stent around 24 millimeters. When we look to the pulmonary vein monitoring, what we get at the same time, with the first balloon, you see a fall in the right atrial pressure, a rise in the left atrial pressure, but a super high rise in the pulmonary vein pressure, indicating obstruction. And this again, you see that on the Doppler, the balloon's inflated. There's only a tiny jet of pulmonary vein flow into the left atrium, continuous flow on the pulmonary vein Doppler, clearly unacceptable. With a smaller balloon, we find that the RA pressure does not fall, although LA and pulmonary vein go up and simultaneously. So there's no obstruction, but we haven't sealed the leak. And again, if you look at the Doppler, you see laminar flow in the pulmonary vein, but a significant leak here, and nice laminar flow in the pulmonary vein Doppler. So we've evolved this strategy we call pulmonary vein protection. Here you see the pulmonary vein running past the SVC into the left atrium, and this is the communication. By putting in a stent in the usual way, you end up potentially blocking off this pathway from the pulmonary vein into the left atrium. If, however, you place a balloon, a high pressure balloon in the pulmonary vein, when you inflate your stent, you can see that this molds around this balloon and prevents it blocking off the pulmonary venous pathway. So here you see we've done this. The balloon's inflated in the pulmonary vein, the stent's implanted, it's inflated. You start to see a little indentation where the balloon is, and after further flaring, you can see you're left with a significant indentation here to allow the pulmonary venous pathway through. when we inject here, you can see good flow into the left atrium. There is still a tiny leak, which we deemed acceptable in this setting. And the pulmonary vein, you can see on the lateral, is completely unobstructed. At this point, there was the potential for, particularly if the stent bulged that way, of obstructing this pulmonary vein. And again, the pressures are useful, RA pressures fallen, LA and pulmonary vein shoot up. And again, we have laminar pulmonary vein flow and only a tiny little leak there. We also use a hybrid stent. Here you can see this right upper pulmonary vein dye holds up, so we know we are going to have to protect this pulmonary vein. But in addition, there's a very high pulmonary vein, which you can see much higher than the catheter in that lower right upper pulmonary vein. There's no way we will be able to divert this into the left atrium. So what we use is what we call a hybrid stent. We first place a bare metal stent on this 8 centimeter long balloon. Then we put a covered stent over this balloon so that you now have covered stent for 6 centimeters and 2 centimeters of uncovered stent. Inflate this combined stent. There's the protective balloon just to give a little bit of an indent. And then when we now inflate at the bottom of the stent and inject in the SVC, you can see that the bare metal struts allow this pulmonary vein to flow and it's not been blocked off. And at the bottom now, after pulmonary vein protection, we've got good flow of the main pulmonary vein into the left atrium. There's a tiny leak there. One of the things we're aware of is that high pressure in the pulmonary vein in a freshly implanted stent with heparin on board may allow some tracking around the stent that is not seen when the heparin wears off and the pressures rearrange themselves. This is a patient who's had a transvenous pacemaker in the setting of sinus venosus defect, a right atrial, right ventricular lead. And you can see the right atrial lead in good position, but the right ventricular lead is actually sitting in the left ventricle, having gone through the defect. So at a single procedure, we extracted those 2 leads, implanted the stent, covered stent, and then placed a new pacemaker into the right atrium and right ventricle to deal with the problem. We followed some of these patients up for a long time, but at 1 year, we tried to do an MRI scan. The QPQS invariably falls quite considerably. The right ventricular end diastolic volume index falls, and the RV to LV ratio falls. We've now implanted stents in 55 patients. We only used the covered CP stent, age between 15 and 74 years of age. We've had bilateral SVCs in 12. We've blown up a balloon for pulmonary vein protection in 14. In one patient, the stent embolized before discharge and the patient had surgical repair. We've had one patient who was restented for a residual leak. Follow-up is from a week to over 7.5 years. The QPQS on average has fallen from 2.6 to 1.2, and the RV-EDV from 154 down to 95. So our conclusions of Evelina that we can close probably around 3/4 of patients. Very low incidence of residual leaks. We've not seen sinus node disease and no SVC or pulmonary vein stenosis. We know it avoids morbidity of stenotomy and cardiopulmonary bypass. Stent instability remains a concern, but we can avoid that with longer and additional anchoring stents. And we believe pulmonary vein patency is paramount. Now, as Pablo mentioned, we've started a registry, an international registry, currently 53 centers, and I'm pleased to say that Latin America has contributed to this. Between 2011 and 2023, we've now got 381 patients, age from about 5 up to 87 years, 14 patients under the age of 10 or less, 16 patients between 11 and 16 years of age, weight between 17 and 160 kilograms, bilateral SVCs in 58. There's been a high accessory pulmonary vein in 63, and follow-up in the registries from 1 week to 12 years. These are the centers that have contributed to the registry. You can see the highest number have been from India with 117 cases, predominantly from Chennai with Shivakumar. The Near East in several centers, about 48 cases. In Europe, 155 total. The UK has got 77 cases. France, a fair number, and then much fewer in Germany, Ireland, down to Spain, only one case that we know of. The Americas seem to have a slightly less number than one might expect based on populations, 7 in Canada, 37 in United States, and then in Latin America, Mexico, Brazil, Argentina, and Chile have all contributed cases to the registry. Looking at the increasing frequency of cases, the first ones were in Iraq in 2011. In 2015, in Chennai, they put in their first stent. We did ours in 2016. But since then, the number of cases per year has been increasing year on year, with over 100 in 2022. But in 2023, only the first 2/3 of the year, we're almost approaching that, and I expect we'll be well above that by the end of the year. The number of centers has increased. Back in 2016, it was only 4 centers, and now 53 centers that have contributed. And I expect both of these trends to increase over the next 2 or 3 years before plateaus. What stents have been used? Balloon expandable in the majority, 237 with the 10-zig covered CP stent, less so with the 8-zig and with the G-armor version. Here you see the 10-zig stent and the G-armor. Optimus and Andromed over here, and the Zephyr stent starting to be used in India more, and then the B-graft, very few stents, very few procedures. Self-expanding stents, there have only been 17 in the registry. The Zenith 1, the Endurant with 10, and the VB stent 5, and here the Nano stent, which I gather we're going to talk about a bit more, has been implanted in 1 patient in the registry. So in summary, more than 380 cases across the world, 2.6% have ended up with surgery due to embolized stents. 2.4% have required an additional procedure, either an additional stent or an ASD device. The 10-zig stent is currently the most commonly used, but new stents are emerging, the Optimus, Zephyr, the VB, and the Nano. The obstacles to wider uptake: conceptual, pediatric, adult congenital surgeons, it's a surgical condition. How is it possible without blocking the pulmonary veins? And regulatory, approval for longer 10-zig and newer stents to facilitate the procedure is just lacking. And most places around the world, these stents are used on a named patient or some kind of exemption rather than as a standard procedure. I think I'll stop there. Happy to take any questions. And if I stop sharing, which is...
Thank you very much, Professor. It was a real thrilling presentation. We are so glad to have you here. I learned a lot. I think I have many questions, but
I wrote mine also. I think we can talk other discussion about the procedure and the technique that you are looking, that you show with extremely quality, and at the end, especially the how to deal with the patient after the procedure. That is a question that usually asks to me about the risk and the behavior of or beware about thrombosis of the stent. They are going to talk about. Now I think we are, can introduce. I'm going to introduce a little of the patient, the case report they are going to do, and then Ariane is going to show and Anderson the technical approach of this particular case. I will show now. This customizes the title of our webinar, that is a customized and repositionable device for sinus venous atrial septal district closure, the first in man experience that is made by the nanotechnology and the 4 valves TV. This particular case, it was an 83-year-old man with a class 4 the New York Heart Association, with right heart extreme overload, but volume overload, with such a desaturation and in cases of right to left shunt, but without hypertension in anasarca and oxygen dependency, and was admitted looking to tricuspid valve treatment. Please, I'm going to stop my share, and now Ariane is going to show the TC of this particular case.
Okay. Let's share. Okay. So let's start by understand the MPR view from CT scan. Actually, my first step in all cases start with MPR view. First, evaluate image quality. That is very important. And then I try to understand the anatomy and provide some measurements using MPR view. Here you can see superior vena cava, left atrial, right atrial, the big communication between them, azagus vein. So in this particular case, our concern was about the size, the large size of the defect, with measure 49 millimeters. Also, you notice a big difference in the size of the superior vena cava between the top and the bottom of the defect, how you can see here. And another problem was that the pulmonary veins arrive at different levels, and we were concerned that the upper and middle pulmonary vein might be occluded by the device. How are you going to see in the next step? I think everyone agrees that 3D reconstruction gives us a new understanding about the case, because we can see the real problem now. Here, vena cava, pulmonary veins at different levels, azagus, the ostium, left atrial, right atrial. And with this model, I did a virtual prosthesis simulation. Nowadays, this software allows for some customization of the device, and I tried to do that. However, I was unable to activate the true size of the device in this software as projected by Nano. And so I tried to virtually build the prosthesis using simple shapes just to provide a better sense of size and perform image fusion in this other software. And then I sent to the printer. In this prototype, I have used flex resin that is sufficiently transparent and flex for this case. I guess we were very confident after testing the prosthesis in the 3D printing. But I think I'll leave this part for Pablo and Max to talk about. Just to stop, please.
Thank you very much for your presentation. Kindly, nobody can show image with TC reconstruction and printing like you do. We have a good impression about Ariane Pacheco here in Brazil. Oh, Anderson, I have to explain that Anderson makes a special participation in this case because he has the idea to use exactly this kind of device. When you're making a diagnosis, he was together with us when making the diagnosis exam and said, I have an idea, I have I know a device that can fix this extremely large problem. So the first idea were him. So Anderson, talk about the nanotechnologies and the nano device.
Max, just one second. Before Anderson starts his presentation, I'll have a question for Professor Rosenthal.
Oh, that's right.
But Professor, looking at this case, what would you suggest? What are your impressions of the anatomy of this case? First of all, I want to ask you why this patient would desaturate. Your mic is on.
Yes, we've had a similar patient with this kind of anatomy, which clearly is a complete challenge to any balloon expandable stent and most self-expanding. In fact, we looked at using the aortic stent grafts to see if we could somehow make a hybrid stent where you used a balloon expandable at the top so the stent wouldn't expand too much near the pulmonary veins, and then you needed to flare out with a self-expanding. But even the current stent grafts wouldn't work in my patient, and I don't think would work in your patient. So I can see where you're coming from with the stent you've proposed for this patient, because there's nothing else on the market that would approach dealing with it.
Yeah.
I suspect the patient is desaturating because it's almost like a common, the defect is so large that it's like a common atrium in a way, unless you tell me the patient already has pulmonary vascular disease, in which case.
No, it's very odd because the patient didn't have pulmonary hypertension so far, or mild, I should say, but he had a torrential or severe TR. I think that the saturation was because
the TR is going straight back through the defect. Yeah.
Okay.
No, that's a very interesting. I've seen one similar to the size problem, but not with the clinical issue of desaturation. My patient is one who actually is on nocturnal ventilation for airway breathing problems, and I don't think we can even take it for a general anesthetic to do anything to her. And doing it even under local anesthetic, if there's a problem, we're in trouble. So my patient can't even have a procedure. But I think your patient has both the need for closing the defect. You won't get rid of the TR by doing this, but you'll get rid of the effects of the TR on the saturations. And of course, there is still presumably a large shunt anyway.
Thank you very much. Anderson.
I'll share my presentation. Everybody can see?
Yes, we can. It's good. Go ahead.
Okay, thank you. Good morning, everyone. I would like to thank Valves for the invitation and to say that it's a pleasure to be here discussing science and innovation with all of you. Okay. Oh, sorry. Not working. Okay. So I'm a cardiovascular surgeon from Manaus with expertise in endovascular surgeries. Introduction. So we now know that classically the correction of Sinus Venosus ASD is surgical, whose techniques not only to occlude the defect, but also to redirect the pulmonary veins that happen to drain to the right atrium or the superior vena cava. But Professor Rosenthal already showed us that the endovascular treatment has great potential using cover stents, but here we address this issue using endoprostheses. However, for which type of patient we should use this technique? And should this procedure be developed in the environment of the heart team? So, endoprostheses are self-expandable release device with low radial force. Delivery systems today have profiles ranging from 16 French to 20 French in the most diverse brands. The customization of these processes opens up a huge number of opportunities for the treatment not only of aortic pathologies, but also intracardiac defects. But prolonged manufacturing time and high cost are still a barrier when we think of large international manufacturers. Nano, which is a Brazilian industry, can address these two problems with delivery time up to 30 days and low cost when compared to international competition. Now I'm going to show you some Nano Apolo prosthetics off the shelf to understand the possibilities of customization. There are prostheses with single-thread nitinol stents coated with EPTFA tissue with sutures only at the ends. This is a thoracic size. They range from 22 to 43 millimeters, but it can reach up to 50 millimeters, and it can be straight or conical. This dissection prosthesis that we use for as a thoracoabdominal extension in cases of dissections, aortic dissections, in order to increase the diameter of the true lumen, we see that we can have a good number of free stents. The bell-bottom iliac extensions are already conical prostheses with a difference in proximal and distal diameters up to 10 millimeters. And the aortic uniiliac process, we can reach up to 25 millimeters difference. But it is the customization of these prostheses that enable the treatment of the most varied anatomies of the aorta and the iliac artery. Here we can have branched and fenestrated prostheses that can be precannulated. We can have scallops and windows. It can be conic. The free flow could be double, and we can have it proximal and distal, and you can have prostheses without free flow. We use a lot of branched and fenestrated prostheses to treat aneurysm and dissection of the aortic arch. Now, here's an example of fenestrating and windowed processes in a case of arch involvement. Here we use the window to preserve the brachiocephalic trunk and left carotid, and a fenestration to maintain the left subclavia. Another feature of the prosthesis is the controlled release. The controlled release and possibility of repositioning are very important characteristics in challenging anatomies because they increase the success rate of treatment and decrease the complication rate. So the conventional release of this prosthesis is a pullback type followed by a free flow release that you can see here in this video of iliac branched prosthesis. The process can have a restriction system of 50% of its diameter after it is fully unsheathed. Here in the left, we see the prosthesis is still restricted. Then we can address the fenestrate part, and at the right, the fully released prosthesis already. It can have a reposition and a recovery system until the final moments of its release through PTFE wires connected to the distal end of the prosthesis. You can see how to do it. The release of proximal free flow can be partial too, leaving a single fixed fin in the release system, allowing even after the formation of the final structure of the prosthesis that is repositioned, like you see here in the right movie, the movie on the right. So this is the journey of this prosthesis from the aorta to the heart. Professor Rosenthal has already brilliantly presented the use of covered stents in effective for a good part of anatomies. And he detailed in his article the anatomical features that it can be used. But for extreme anatomies, as Ariane has already detailed, you have to think outside the box. Here we have a case. Our case has a conical neck and an absent distal fixation. So after all the work of measurement and 3D reconstruction, we choose a customized 31 per 50 per 65 millimeters Nano-Apolo in the processes with Voyager system. That's the system that can reposition and retrieve the prosthesis. And we could deploy this prosthesis at the 3D model that the Ariane made it to test the feasibility of the procedure. So concluding, the endovascular treatment of the Sinus Venosus ASD is a rapidly evolving technology. Covered balloon expandable stents are the most used to date. The use of a customizable endoprosthesis may be the key to the treatment of diverse and complex anatomies. And for my opinion is that is a heart team approach is the best for this case. Thank you.
Thank you very much, Anderson. A great presentation about the device that you suggest to use it because you know it very well. I think that it's important to introduce the case itself instead, Pablo, and then we start with the discussion about the topics. Professor Rosenthal can interrupt to ask questions about comments during the presentation without any problem.
Max,
Sim.
Professor Rosenthal, it's with us? I think so. Your mic is off. Do you?
Yeah, there was a connectivity issue. I had to join it again, but I've got Wi-Fi back.
Okay. So
no, I saw that last presentation. It was just for at the very beginning. It's cut out, but I am here.
Do you have any question for Anderson about this special device or some curiosity that you want to know?
I think the real question for me with the self-expanding stents is one, the anchoring, because if you have only got a short SVC or a very conical one, I can see how it will milk out of there. And I know in the past people have used self-expanding stents with hooks on them to catch into the tissue. That is not completely risk-free. There's been at least one case where that perforated into the aorta, and the team in India who use these a lot now actually lay down a balloon expandable stent first for the hooks to catch into rather than hooking directly into the tissue. But that's just an interesting thing. So for me, you need something to make the stent catch in the nominate vein in the azygos rather than just holding onto the wall as you do in the aorta, where it's a much more uniform diameters and you have a long landing zone. But here in the SVC, you may have a very short landing zone and you need something to anchor it. The second thing that always worries me is because of the continued expansion, it will always try to achieve the maximum diameter that it can. If it's opposite the pulmonary veins, these may be at risk. So I know there have been cases done and have been done well with the self-expanding stent, so I don't have a problem with it. I'm just, because I don't use them, I'm really interested to see how you avoid it expanding too much around the pulmonary veins. So the two things with the self-expanding stent is it's gripping and holding at the SVC and not embolizing, and the second is not blocking the pulmonary veins. I'm certain that it will be able to close the defect because it has the size to be able to do that. But the two other features are, I'd like to see what happens with this case.
Yes, I think we can discuss it in the end because it was a worry of all the team where, because to be very honest, we had some discussion with Professor Shek Qureshi before because we have showed him this case and he just said what you're saying to us now. And we have these worries and that's why we didn't have these barbs, these fixation barbs. And we always, and then I'm gonna tell you in the end of the presentation, one of the features that we have to work because this is in development project, and we have to work it out in the future. Okay, Max, can you? I think it's time for you to show the case, isn't it?
Yes, I'm going now. I'm going to share my screen. And continuous presentation at this point. We said that this patient originally was admitted with class 4 New York Heart Association, extremely overload, the volume overload, and oxygen dependency, but trying to looking for treat the valve treatment, the tricuspid valve treatment. These were the tricuspid valve when we admitted the patient, and we discovered that they were very huge, but it was not the real problem of the patient. It's important when they are looking at the septum, we're trying to find the atrial septum defect, to pull back the probe, not to make a mistake to miss this kind of defect. You have to look at the roof of the right atrium, and this is where the defects are, the Sinus Venosus atrial septum defect. A very, very huge one with a very, very large superior vena cava right atrium connection. These were during the cath lab to confirm, deployed a pigtail on the right artery, pulmonary artery, and show the flux, the drainage. And here, the flux from the left to right shunt from the left atrium to the superior vena cava. The connection is not through the septum, but through the superior vena cava and the superior vena cava to the right atrium. A very huge 3.9 centimeters, so 39 millimeters height. Here, we have 2 points, orthogonal view. There is a very huge defect, and this is the right pulmonary artery that is very, very large. 41 millimeters diameter is the diameter of the right pulmonary artery. That's important because he's going to be the point of reference. This is the vision of from the right, the left atrium to the right atrium that you can see the defect, and the superior vena cava on the bottom of the image. Here we have a catheter during a wire in the superior vena cava, both the defect and the diameter, and we can see it at the 3D passing through the superior vena cava. We're looking from the left atrium. This is the right pulmonary vein flux going in the left atrium. Here we have the tricuspid flux without high hypertension, but it's a very, very huge volume of tricuspid regurgitation. So the pressure were not expected to be so high. But if you are looking at the artery, the right pulmonary artery flux, you look at that doesn't have a premature peak. So the acceleration time is almost 100. So the vascular resistance is not so high. The balloon expander during the procedure, this was an Atlas gold balloon that make a obstruction of the upper superior vena cava. Then we confirm that it's not interrupt the flux from the pulmonary, right pulmonary vein to the left atrium. The view here is interrupted. And here, when injected, I can find the cath lab imaging. We can the cath lab contrast in the left atrium through the left pulmonary vein and the right pulmonary vein achieve the left atrium. And here the diameter 3.1, 3.2 at the superior vena cava diameter, that's the balloon diameter. This is the mitral flux at rest and during the balloon. You can see that we can not have a very, very high pressure of flow, preload pressure of the left ventricle. So it doesn't matter, it doesn't take instability on the ventricular function. And here, an area that still remains up with the balloon, where the aim of our project to preserve the drainage of the flux to the left atrium. It's important to separate when you're talking about superior vena cava sinus venous atrial defect, that it's important to separate drainage from connection. We are not working on connection veins, the connection of the veins. We are working on the drainage. We still have the connection of the pulmonary veins on the superior vena cava wall, but the drainage of the flux is separated to the left atrium. Here we are going to the procedure itself, make a pulmonary inferior vena femoral vein, and then go to the jugular vein to achieve the upper part of the heart and to make fluid and the contract injection. Then the pigtail on the pulmonary artery, right pulmonary artery, to show exactly the level of the device deployment. Here we have chose we'll make a first device, then test in the printing model, and then we perform as official device. At release that Anderson chose, it can be repositionable until the complete release. Sim.
Can I interrupt you?
Yes, of course.
Just to show that the landmark is the azygos vein, that we have some contrast medium retaining there. So we were thinking to release the free flow there. And I know that Professor Rosenthal raised his hand. He wants to make some comments. Please.
Sorry, I missed it. Is it deployed from the jugular or from the femoral vein?
From the femoral. But we had a rail, a venous rail from the jugular with a 12 French sheath, and the device is 20 French from the left, from the right femoral vein. But as you can see, Professor, at this point, the main body, if I should say, of the device is not completely deployed, and the free flow is the last part that is released. And I think that we should work in the future to begin from the free flow, to retain the device first at the SVC level. What do you think?
Well, that's the point I was thinking, because you just don't know how well adherent that part of the stent is at the moment. And presumably it's no longer recapturable at this point.
No, it's recapturable in this point. As you can see, there's some tethering, catching the device from the bottom part, and we can still retrieve it inside the catheter and reposition at this point.
It's possible to do that.
It looks impossible for me to see you doing that. So could you do that, please?
But Anderson showed in his presentation. Maybe...
No, I saw the recapturing, but I thought the sheath was coming from above there.
No, it's coming from below the sheaths.
No, I get it. I thought you would be capturing it from just the point where you haven't released the free flow.
Because there's another points here that we can, with wires, that we can pull it and reduce the diameter. It's not completely free. The free flow is not completely free now.
Anderson, maybe after Max presents his case, you can get back to your presentation and show the tethering movements to retrieve it.
Oh,
what
yes.
Do you think?
Yes, for sure.
Okay.
I'll go on here, the next slide, to confirm the drainage to the right atrium from the superior vena cava, the jugular vein, and the trunk venosus, brachiocephalicus, to perform the superior vena cava. And then when they release it, they fall down. They go much more lower than we prepared or expected to be. And this point, and the reference, this was the results. The first result that became lower than we expected for. Then we started to recatch all, you can see here, that is lower at the level of the fossa ovalis, much more lower at the longer and farther than the crista terminalis, than the references. Then that's why they made by Paulo Mota, that make a left jugular vein punction and make with a snare catch it
the free
flow part, and catch it and pull it back. In this point, we can see the pullback moment at the echo. You can see the pullback moment, and then the control at the high level, and release the wire, preserve the part, the drainage of the right veins to the left atrium, preserve a space in the superior vena cava. The final result here at the level of the cilia terminalis. And here we can see the 3D blocking the communication to the superior vena cava. And this is the right pulmonary vein flux going in the left atrium. And the final image, we can see the vein time, that we can see the drainage of the pulmonary, the flux to the left atrium, including here the septum, the mitral valve, the appendage, right, left atrial appendage, and all the most part of the flux is going to the left atrium. Quite a little bit here to the, we can see connection, the drainage to the left atrium.
Max, I have one comment here, and including for Anderson and Professor Rosenthal. I think that we could work in the future in two features. The first one is that for the aortic side, they used to oversize the prosthesis by 20% of the diameter you want to treat. As we were in the venous side, and it was the first case, we thought that 30% would be a nice number. And I think we could do 20% oversize in the future, because I think it was one of the reasons that we had this migration. And the second point is the free flow would be released in the beginning, as I said first, because it generates too much tension, and it has dragged the device down. I think there are 2 points that we have to work in the future. What do you think? Professor Rosenthal, what do you think?
Okay, so could I just ask Max, could you just go back a couple of slides
Of
to
course.
just before you released it? Because that's the question I had, and that's why I'm not sure I fully understood. So at this point, you haven't released it, and you say it is held on by tethers at the bottom end of the stent. Is that correct?
At this point, we assume that this point will be at this time, this part, and fall down. It was pull it back to the right atrium. But
I can show Professor Rosenthal what is it.
So what I'm trying to get is, at this point, could you collapse it completely and put it back in the sheath or the covering?
Yes.
Or would you just have to take it and lose it?
No, yes, you have to. You can do that and release many times as you wish.
So I think I would have thought, is that not just at the top marker on the delivery system? Is that contrast in the azygos vein there?
Yes.
Because I think what I would have done intuitively would have been to, if you can at this point, I would have recaptured it and tried to deploy it so that the free flow is actually at or even just above the level of that azygos. I think that would have given you more.
This high, this point, at this level.
Yeah. If you could have got it up to there before releasing, it would be less likely, I think, to embolize. So then if you go on to the next, so at the moment it's completely retrievable, but I don't understand, where are the wires attached to it at the bottom end of the stent?
I can show you. Let me.
The point, Professor Rosenthal, that pull it back to this point, we're not allowed to cover the bottom part of the defect here.
Yes. Yes. One thing that we learned after this.
I think then you have to build a stent that's longer at the bottom.
Yes. Yes. At first, we thought something about 100 millimeters device, and then we reduced the length of the device, and maybe in that case we should aim landing zone more than 4 millimeters in the future, more than 40 millimeters.
This device is actually 85 millimeters long.
With the free flow, yes.
Yeah.
One of the problems during the design of the device, this particular device, was as explained by the nano factory people, that the degree of progression of the diameter has limits, so cannot be progressed in any point, or that we can at this level I have to have 30 millimeters. This point I have 30, and this 40. The degree of the progression has limits that we have to respect.
Can you make the free flow portion longer? If you'd made that free flow portion twice as long, I don't think you'd have had a problem.
Yes, you actually can have how long you deserve uncovered stents, and you can put it at the common vein, at the nominate vein.
You can put it at the nominate, even into the jugular if necessary, half of it, and some of it fall into the innominate. So I think exactly where your position is now, I would want a doubling of the length of the free form, and then it would have stuck beautifully, I would have thought, first time. I mean, congratulations on pulling that thing, of recapturing it and pulling it up, because having done that, I would almost certainly have put in an anchor stent to keep it in place. And I think you were very brave to just say, we've got it there and it's fine. I really wouldn't have trusted it.
Paulo Mota is extremely abilities with catheters, and he performed the snare. He snared the device, and then the problem was the behavior of this point was not that as planning what I expected for.
Is that because it was already constrained at the bottom and it was caught on the SVC-RA junction, so it wouldn't?
Yes,
but you're not pulling it up. You see, again, you would have thought if you were delivering it from the SVC and releasing it.
There was a lot of tension that was concentrated, that was released at the moment that we released the device on the top. The tension on the bottom of the device were the tension was released. Then they pull it back.
I'm not sure if you've seen the VB stent, which is similar in a way, except it's deployed from above. And so you release exactly as you do the right atrial side, and then you pull it up to engage, and then you release the free flow portion, but you release it from above, so that I think you have slightly more control on pulling it up. Here, you can't push it up anymore. It's not going to push up.
It was much more lower than we have to do, and then it's snared it, and we are allowed to pull it back.
Have you actually gone through the struts to be able to pull it like that?
Yeah, it was only possible because it was the free flow. So
you went through the struts to do that. Yeah.
No PTFE. So it was the only way to catch it from the left jugular with the snare.
The flow part.
I have to say, if I'd got it to that point, I would then have, from your jugular, pushed a bare metal balloon expandable stent and just trapped it at that point. I wouldn't have trusted it holding on, seeing that it had fallen out once. Obviously a great result, but I just, looking at what you've got to there, if you could have just a longer free flow portion, then I'm sure it will be much safer and much more reliable way of doing it.
Yeah, look at here. Okay, the final flux.
Yeah, because you see, twice as long as that would be sitting in their nominate, and then you would definitely have good anchoring. And
Yeah.
The point is the pigtail of the pulmonary artery is at the middle of the artery. The artery was from this point to this part here, 40 millimeters long. Here, the right here is the point of the right pulmonary artery, and the final the space through the outside the device and the vein, the pulmonary vein, and here the final flux showing most of the flux, all the flux going to the drainage, the pulmonary vein drainage on the left atrium. That's important, doesn't it, Professor Rosenthal? The
pulmonary vein drainage is obviously the paramount thing. As I say, there are three things: sticking in place, blocking the hole, and preserving the pulmonary veins. And we've done all of those, so great result. I would have felt nervous, but obviously the patient has done well, and so congratulations on that.
We have the control of 2 months TC control that Ariane is going to show now. He was performed this week. The patient is completely without any support of oxygen support, and has at the beginning of the process, or 2 months ago, no edema, it's class 1 of the New York Heart Association.
I can? Sure.
Yes, I going to stop now.
Okay.
And now,
Mm-hmm.
Ariane, show yours. I have to press.
Okay.
I have to show mine.
Okay. You can see my screen?
The stent is still there.
I have to stop mine.
Okay.
Yes, we can see. Just
okay.
Slideshow. Yes.
Okay. So this is a CT scan after 2 months. So in my opinion, despite the deformation and some retraction here, it effectively closes off the defect without affecting the flow from pulmonary vein, how you can see here. Although the small vein here still remain connected to the vena cava here, but other veins connected and the flow from the pulmonary vein to left atrial is totally okay.
Doesn't have any clinical any clinical problem. Those kind of vein connection, Dr. Rosenthal.
Okay.
I don't think so. I mean, depending which surgeon you talk to, they say they can redivert any vein when they operate. But in practice, when we go to the operating room or when we read the operation report, they've left the little veins behind. And I think that makes sense. The last thing you want to do is cause an obstruction to a vein for no good reason. It's much more sensible to leave those veins draining either just above or through the struts of the stent. I think that's perfect. I do think so.
The price to block all the veins is too high. Perhaps you can pay with complications.
Exactly.
And of course, this patient wasn't a candidate for surgery because of the age and the clinical complications.
Not at all.
I have some questions for Professor Rosenthal because
Pablo,
before,
first of all, I think that Anderson is going to show again to Professor Rosenthal the maneuver to recapture the device.
Good.
That is different.
And what's the biggest diameter you can have at the bottom?
55.
55.
Yeah. My patient needs 65 at the bottom to feel it.
So, Professor Rosenthal, I will show some slides here. See, here we have a dissection prosthesis that we have free stents here, so we can make longer that we can. And
sorry, Anderson, I saw your presentation on the variations of the stents and the length. I just missed that point about how it was attached right at the end.
Okay, sure. Sorry. Here, you can see it's being retreated, and the mechanism is by this PTFE wires that is attached to the bottom end of the prosthesis. So it goes inside the catheter, and here's the mechanism of the Voyager system that you can pull these wires and recapture the prosthesis, even as it is full released.
But now on that one, are you release? You see, that looks like it's being released from the top end.
You have 2 points of it. You are at the top and at the bottom. You have here. There's a point that it's catched at all. Then it's released from the bottom and it's catch on the top.
Yes, and choose the Voyager. The prosthesis has to be attached the proximal end to. Here we didn't have at this case this feature, but we can partially release the free flow. So it has 4 wires attaching the free flow to the delivery system, and you can release 3 of these wires and leave just one to roll the prosthesis, so it can achieve its final form and reduce the tension of the prosthesis. So we can do this in the next case, and this time we still can use the Voyager system to retrieve the prosthesis. And we can do the processes with a longer free flow or a longer part of free stents, uncovered stents.
Professor Rosenthal, I have a question to you about, first of all, the technique of the diagnostic, part of the procedure of the cath. You said at the beginning that you use a compliant balloon. When we started here in 1917 with Professor Chamier, that you name it on your cases report, we use a non-compliant balloon. We use the order were to use the same balloon that you are going to use at your device. At the CP stent. What was the experience when we started? We used the 45 long CP stent, then the 6, and now we have the 60 millimeters long CP stent. But they said to use the same balloon that you are going to use the procedure to achieve the same physiological behavior of the superior vena cava and the pulmonary vein drainage. Doesn't it? Is you use the same way, because you said that you use the compliant balloon and explain the differences.
So we started off by using the compliant balloons, and I still think that if you use a compliant balloon and you don't obstruct the pulmonary veins, you know there's no concern about obstructing the pulmonary veins. If the compliant balloon obstructs the pulmonary veins, then you either abandon the procedure, and that's how the balloon implantation, the stent-mounted implantation developed. We then moved to using non-compliant balloons of a size that we thought we would implant a stent on. But there's a difference between the size of the stent that you need to anchor in the SVC and what you need to seal the defect lower down. So the first thing you want to do is choose a stent that you know will stick in the SVC. The second is you need to know that when you flare that stent further, that it won't obstruct the pulmonary veins. And so because you never know exactly the difference, how much expansion you need at the bottom, one of the reasons why I often go for the non-compliant first. The compliant first. But having said that,
if you have problem with the compliance, perhaps you are going to have with the non-compliant too. That's the idea.
No, I mean, if you have a problem with a compliant balloon, you may be okay with a non-compliant balloon. You could say, why not just go straight for the non-compliant balloon? And I think we do sometimes. I think if it looks to be borderline suitability and the veins may get obstructed, then I often do start just with a non-compliant balloon, because then I know I'm not going to oversize it. But in that sort of patient, if you use a compliant balloon, you will always block the pulmonary veins, and then you don't know where you are. Either it's because it's not suitable, or because you've blown up the non-compliant balloon too big. The compliant balloon too big. So I understand there are people who just go straight away for non-compliant balloons. I've got no argument against that. It's just been our practice to do that. And, you know, sometimes we hold on to things we start with. Sometimes we change. I don't have a problem with anyone saying I tried a non-compliant balloon of 28 and went to 22, and then I picked something in the middle, or whatever you need to do.
The experience, do you think that when you use an ACP device or expandable or self-expandable or balloon expandable devices, when you are at measure or the size that it allows is the first option for you? Use the CP stent?
For me at the moment, my first choice is the CP stent. I've put in 70 or more of these, both at the Evelina and other places.
The message is, that's the message. If you can do it with this balloon, with this stent, is the first option. Then use the alternative devices that we are showing now.
Well, I'm not sure, because I do think that the alternative devices may have a role, particularly if you can constrict the self-expanding bit close to the pulmonary veins. Now, in a patient where I've got an SVC that's 20 and at the bottom it is 30 or 40, so 20 at the top and 40 at the bottom, but at the level where the pulmonary veins come in, I need it to be 16. If I could have a self-expanding stent that would shape in that way, 25 at the top, 40 at the bottom, but perhaps 16 in the middle, then that may be an advantage. Whereas with balloon expandable, I may end up either blocking the vein or not being able to do the procedure. So I think there will be a role for self-expanding stents.
That's a technical problem to build the device that because we can do a longer 40 millimeters, but the progressive diameter increase that has limits.
Yes, as long as you have a good length of the prosthesis, you can do like an hourglass format. of the
Yeah,
problem.
I mean, have you seen the VB stent? I think there's only been one publication on it. I don't know if you've seen that particular stent. I can share it again if that helps. Let me see if I can find this now. Entire screen. Can you see my screen there?
Not yet.
No.
No.
Yeah. So this is the VB stent, and the way they make it, this one is, I think, 40 millimeters at the bottom. This is 25, maybe even 30 at the top. And in the middle, they have it down to 16 millimeters, which I'm wondering may be too small in some patients. But that means that the pulmonary veins that come in at this level drain around it quite nicely. The problem you have with it is that the azygos vein is often inside here. And if you leave the pulmonary veins draining where the azygos is, you'll decompress down the azygos. So you have to actually block the azygos vein with a plug before putting in one of these stents. But looking at your one with your particular patient, I think you just needed that free form to be longer, and you would have done the job more comfortably.
Professor Erickson, you just talked about it, about the concern on blocking the azygos vein. Dr. Seaver said that was not concerned about that.
No, we don't have any concern about blocking it. And in fact, if I can expand a stent into it so it bulges into the azygos, it acts as an anchor or something, I don't have a problem at all with doing that. But certainly if you're going to leave the veins draining and the azygos draining into the same chamber, you imagine just like with a Senning where you block your SVC and the azygos opens up enormously. I think if you left the left atrium connected to the azygos vein, it might then decompress down the azygos. So I think you should block it if the left atrium or pulmonary veins are still connected to the azygos.
Okay.
Professor,
Pablo, do you have a question?
Yeah, I have two questions, three questions, practical questions, very short. First one, the pharmacological approach after the procedure. Second, in Brazil, we only have the 60 millimeter CP. So if you have only 60, what are the precautions and concernings? What we have to have more to do the procedure? And the third one that I have made is the question before for you, but I want to make it public. What's the limit to treat the patients? Well, it's a teenager, it's a full-grown patient, or what you are doing with the teenagers in England?
So certainly teenagers we're very happy to treat. We have not treated children under 12, 13. I like to think the patient should be pretty well grown, fully grown, and I won't have any concerns about needing to redilate the stent or something as they grow. But I know that Sivakumar in Chennai and Hijazi in Sidra in Qatar, they've done 6- and 7-year-olds, and they seem quite comfortable doing that. We haven't done that, but they certainly have done them. I've got a 10-year-old, and I've told the parents if they don't want surgery, we'll let him grow till he's 13 or 14 and then do it, because I don't see any rush to do it, and might just as well get him to grow properly so we can do it. That's our approach. So teenagers who are more than 40, 45 kilograms, I think are fine to do.
You are expected to you wait to stop when you stop the growth curve, or they stabilize the growth curve or height and weight.
I think when you think they're at least 3/4 grown, whatever your judgment is on that, I would have thought 40, 45, 50 kilograms for sure. They're big enough. The SVC is not going to change that much. Even if they grow up to 70, 80 kilograms, it won't change that much relatively.
not at the point to be a problem of stand like other congenital heart disease, that
No,
especially pulmonary arteries on branch.
Yeah.
Bronch.
But as I say, in India and in Qatar, they've put in 6, 7, 8-year-olds. There was one 5-year-old, I think. We don't know the long enough follow-up on them to know for sure, but they seem happy enough with it. There may be 30 patients. Certainly in the registry, there are 35 under the age of 18 in the registry.
So if you can wait, it's better to wait.
I think for me it makes sense. If you've got an 8, 9-year-old, you've missed the boat for doing the operation before they went to school. So you know that many of our adults turn up in their 30s, 60s, 80s with this defect. So I think waiting 3 or 4 years at that stage isn't a problem. If the parents are happy with it, then you can avoid surgery. In terms of, we give aspirin and clopidogrel after the procedure, 6 months of aspirin and 2 months of clopidogrel. I think if the patient is already on warfarin or a DOAC because they are in atrial fibrillation or they have other conditions, then we would just continue with that and use that as per their underlying disease rather than changing them to aspirin or clopidogrel. We've not had any thrombotic issues. In the registry, there are about 10 or 11 patients with thrombosis. Sorry, correction. We've had one where the procedure was very long and we got a clot forming on the guide wire between the jugular and the femoral vein, and we had to use a sheath to aspirate the clot and then carry on with the procedure. There have been 4 or 5 cases where jugular vein thrombosis or clot on the atrial septum during the procedure. Most of these have just resolved with heparin and not caused a problem. But there have been 4 or maybe 5 cases, I'm just working on the registry at the moment, where clots were noted at 1 to 3 months afterwards in those groups that do a TEE as a routine. We don't do a TEE as a routine, and so I don't know whether there's a difference to that, but certainly our transthoracic echoes have not showed any clotting, and we do make sure they all get a CT at about 2 to 3 months, and we get an MRI at a year in all of them. So I do think it's important for heparinization during the procedure, and particularly long sheaths and the standard precautions you would use for any catheterization procedure. But I think it's worth being obsessive about it, and then definitely give something afterwards. We use aspirin and clopidogrel. If people say they want to use warfarin for a few weeks or months, it's not unreasonable either, but we've never felt the need to do that.
And do you have another question, Pablo? There. And I will ask you about the hybrid concept that you have shown, using a second device approximately to fix the position when you are going down. You have to do in your experience many times, or just is an exception?
Got it here somewhere. Hold on. I'm just looking up the data. So how many? I think probably 1 in 3 or 1 in 4 we would put in an extra stent to anchor the top stent.
You have to be prepared to do that, but you don't want to do that. But you have to be prepared.
You have to be prepared. I really don't mind now if I just have to put in an 8-sig uncovered CP stent. It's very quick to mount, to push up, put in, and then I don't have to worry about it. I've only had 1 embolization, and I don't want to have another one. And so I think, Pablo, if you only have the 6 centimeter CPs, you can usually do most defects with that as long as the SVC is less than 28 millimeters. I think once you get into 28 and 30 millimeter SVC, the stent is going to shorten an awful lot. and you probably, the 6 centimeters is not going to be long enough. But if you've got 22, 24, 26 millimeter diameter SVC, then the 6 centimeter stent will be fine, but a good proportion of those you will need to put an anchor stent afterwards.
And you put and sorry, Max, you put the anchor stent first?
No. Well, if you put a stent in first, we call that a landing zone stent. Then you put the covered stent, and many people will then put a second bare stent to lock it, and we call that a sandwich.
One the other, this way? One into the other.
So you have your bare metal stent, you put your covered stent in there, and then you put another bare metal inside that.
And
so at the level, at the SVC, there are 3 stents.
But if you have only 2 stents to put, what's the way to do? Only
put your covered stent in, and then your anchor stent inside, because that will trap it between the SVC and the bare metal stent.
Okay, thank you.
And that's one.
But we've definitely had one where we put down a landing zone stent, put in a covered stent, and when we flared it, it just slipped out. So I think I prefer just to put in my covered stent, and then if I think I need to, because it's only short distance or it looks unstable, then I'll put in an anchor stent and then do any flaring necessary.
Okay, thank you.
Like in all the procedures, the knowledge and the experiences curve is a very important point. During the 28, you have done those kind of problems you have at the beginning, or now you still use that maneuvers?
So we lost our first stent after 20 patients. You would have thought after 20 of these, we know how to do it. We're fantastic. We can do it, no problems. But of course, there are always problems. You know that, and I know that. And there have been 1 or 2 centers where it's been their first cases embolized. I think in our institution, if we'd embolized our first stent, they would have said you can't do anymore. Yeah. But as I always say, just because you have a bad experience doesn't mean you should just give up. You just have to learn what you did wrong, accept you've done something wrong or misjudged something, and then move on and do it better next time. And fortunately, we've only lost 1 stent. There are some centers who've lost more than 1 stent, but then there are very few centers that have done many, many stents.
The last question, Professor, is about the pulmonary vein protection using the catheterization through the left atrium to the vein. That is a particular is a maneuver that you make always, or you have tips and tricks of when to do that?
So we do that when we think with balloon testing, the veins look narrow either on the angiography, the pressures, or the Doppler. And we're relying more and more on the TE. And TE can really help you during these procedures. It's really important to have someone who's interested in doing the TE, someone who's there at the beginning of the case and can assess the veins long before you blow your balloon up. Because when I travel abroad, I come to units where they say, oh, well, we'll put the balloon up and then we'll get our echo person to come down and have a quick look. That's not the way to do these procedures, particularly when you're starting. You want your echo person to be there at the beginning, count the veins, what maneuvers to see the veins, see what happens when the balloon goes up, and then watch when you put in the stent. Have you got a leak? And have you got narrowing of the vein? Talking about the balloon protection, there have been 8 or 9 cases where people haven't used balloon protection, but because they've had access to the pulmonary vein, when the vein has become narrowed or the channel has been narrowed, they've been able to put a balloon up and stretch it up. And so you can actually indent the stent and get your flow through that pulmonary vein. So it may be that our protecting of the pulmonary vein is unnecessary and you can get away without it. But again, it's something we feel comfortable doing. And once you've done your transeptal access, you've got access to the pulmonary vein. Putting a balloon in there, inflating it while you implant your stent is not a huge deal. But for me, at the very least, I would have a catheter or a wire in the pulmonary vein so that if I had to come back with a balloon afterwards during the procedure, I could do that.
So you have to do a transeptal puncture to achieve the left atrium and then the right pulmonary vein.
In about a quarter, there's a PFO anyway.
In our cases, I think in 5 cases, just one doesn't have a PFO.
Yeah, so most of them have a PFO, not all.
Okay.
But again, there are places that just do put a catheter up from the femoral vein directly into the vein, into the pulmonary vein, blow up their balloon, take a picture, make sure it's unobstructed, and then take it out and just go ahead and don't bother to have anything in the pulmonary vein while they do the procedure. Perhaps we will come to that at some point, but for the moment, our workflow is comfortable and works for us. But there certainly are people who will just put from the opposite femoral vein straight up into the pulmonary vein through the defect, but not going into the left atrium, but do balloon testing. It looks okay. They'll take the balloon out, take the other catheter out, put in their stent, and just do the rest on TE. So you can do that.
Yeah, it's important that we say the TE, that the people to work with this kind of procedure has to be training or look into the upper part of the heart, not exactly at the level of the
exactly. And I think someone mentioned you have to pull your probe high, and you also have to look posteriorly sometimes, because sometimes you won't see the pulmonary veins. And when you have a SVC pulmonary vein window, which a good third of these have that appearance, when you look in 90 degrees down at the SVC-RA junction, you don't see a defect at all. And it's only when you pull up and rotate posteriorly that you see the defect.
Yeah, that was my first slide said that.
Yeah.
You just look
really
at the muscle valleys, but you have to pull it. You have to go out, and especially I like to do the big. I said it's the whale's tail imaging, that we have the bifurcation of the pulmonary artery, then in 0 degrees, that you have all along the right pulmonary artery along, and then we pull it, and you can see it all the area, all along up to the pulmonary artery also. You have to go there. It's not a common maneuver, not a common way to work, but you have to be to training to look at it. It's not the daily work, but you have to take care about that.
Absolutely. I've not heard of the whale's tail. I like that. My echo lady is going to have to show it to me now.
It's a pulmonary artery bifurcation. I think it's time. We can talk a lot of time here. Pablo, I would like to thank Professor Eric Rosenthal to your precious time and your knowledge. And Pablo, do you want to make your speech, your words?
Yes, just want to thank you so much, all the guys here, for this one and a half hour of brilliant discussions. Professor Rosenthal, thank you for your time, for your presence with us. It was fantastic. And I want to thank our friends Anderson, Ariane, and Max. I have to say a word for Marcelo Seliman from Nano. He was a partner in this case. And I can't forget all the guys in Brasilia, Paulo Mota, Gustavo Licurgo, and all the crew at CT, CV for the support. And I think we have a lot to learn in this field, but we are so excited. We want to move on, and it's very nice to have this support from the guys from Evelina Children, Professor Qureshi, Professor Rosenthal, and so many guys that are helping us. Thank you so much.
And nice to meet all you guys. Thank you very much.
Anderson?
Thank you. Learned a lot, and willing to going to develop the future of this treatment.
Ariane?
Thank you very much. I always learning with all of you. It's a big experience for me. Thank you.
Thank you very much, Dirk. Again, you are very, very proud. Think about your presence, your contribution to our channel, and I would like to invite you. I'm going to share again here. I would like to say thank you to the nanotechnology. I would like to invite you to the next week. We are going to talk about step by step on the treatment of aortic coarctation with the big graft, stent big graft. We have invited, especially from Spain, Professor José Luis Zunzunegui. That will be a great presentation, also like that was today. Thank you very much for your attention, and I expect to every one of you next week. Thank you very much. See you.
Bye.
Bye.